On this episode of The Doctor Will Hear You Now, we had the pleasure to connect and talk with Dr. Boudreau from Our Lady of Lourdes. And I have to say, one of the things that really stood out to me from this conversation with Dr. Boudreau was just about how lifestyle choices can impact your colorectal health. He talked about easy ways that you can do screenings to know where you are with your colorectal health and just to really assess any risk factors you could be experiencing or eligible for based on just your lifestyle or genetics and your family history. One thing that really stood out to me that I think you'll see is that Dr. Boudreau really cares about his patients. And I will never really forget him saying that he's a Cajun who cares for Cajuns. And that's really
Yeah.
important to him and what inspires him. Ben, what did you think? What did you take away from this?
Yeah, I think that's right on. I thought he had a really good perspective, especially being a doctor at Our Lady of Lourdes in Acadiana. And he mentioned the Acadiana area has such a high incidence of colon cancer per the state. So it was just great to hear that perspective from him, acknowledging the lifestyle of being from that area and being a Cajun and the types of foods you eat, stuff, and the celebrating, but kind of acknowledging too the way you have to change your lifestyle and change your eating habits in order to make sure you have a good diet and watch out for your colorectal health for sure.
Definitely. Well, without further ado, here is our conversation with Dr. Boudreau. Welcome to The Doctor Will Hear You Now, a podcast featuring our physicians and other healthcare providers telling their stories, sharing glimpses into their daily work and mission, and showing what it means to practice medicine just a little bit differently. Healing you means hearing you. So let's talk. I'm Lexi.
And I'm Ben. And today we're welcoming colon and rectal surgeon Dr. Matthew Boudreau with Our Lady of Lourdes Health to talk about colorectal cancer and its prevention and treatment. While not the prettiest of podcast topics, colorectal care is an important issue to discuss. According to the American Cancer Society, colorectal cancer is the third most common cancer diagnosed in the United States. We know that preventive screenings for colorectal conditions often have an uncomfortable and difficult stigma, which causes many people to avoid them altogether, which can create serious risk when it comes to catching and diagnosing colorectal conditions early on. In this episode, we are going to discuss the importance of early detection, simple ways to care for your colon, and why it's so important to listen to your body and get your preventive care screenings. So welcome, Dr. Boudreau. Thank you for being on the podcast today.
Thank you for having me.
So can we start by just having you tell us a little bit about yourself and your work for Our Lady of Lourdes Health?
Sure. Dr. Matthew Boudreau. I'm from Scott, Louisiana. I come from a large family. My parents both worked very hard when we were children and instilled in me the discipline of wanting to work. That kind of drove me through college. Eventually, I figured out that I was going to be a doctor. And then I began the long journey of going to medical school, surgery training. Toward the latter half of my surgery training, which is the same way for everyone, you start to have to pick a discipline of which kind of way you want to practice, whether it be general surgery or one of the myriad of specialties that we can do. I actually called both of the hospitals in Lafayette, Louisiana, and the physician recruiter said that there was a need for a colon and rectal surgeon. There was a need for a vascular surgeon, and at the time, a bariatric surgeon. And during my practice, one of my biggest mentors was a colon and rectal surgeon. He was a super down to earth gentleman who was brilliant. And I think that he kind of steered me in that direction just by his compassion for the field and for just general patients in medicine itself. And so through the latter part of my training, I decided to do an extra year where I would specialize in colon cancer and other colon abnormalities. So I had an extra year of training even after the long journey of general surgery. And that's what led me here back home to Lafayette.
That's wonderful. Thanks for sharing that. It's great to hear that, especially one of these topics that are not always the most comfortable, that you really practice with compassion and lead with that. I'm sure that really helps the patients feel, just a little more at ease when going through any of these things that bring them for colorectal care. But what does a typical day in your life look like from start to finish, from home to work and all of those things?
Yeah, so I'll give you a typical week. I have 4 kids. So Monday starts the work week. Monday is a surgery day for me. And actually, Monday is when I try to do my bigger surgeries, my colon cancer surgeries on Mondays. And so I can work anywhere from 6:30 in the morning arrival at the hospital to 7 p.m. or later, or some days I'm done at 3 o'clock. It just depends on how many procedures I have that day, how the procedures go, level of difficulty, etc. Then get home. All of my kids play sports. So almost every night of the week, we are at some gym, field, whatever, going to a sporting event. Tuesday is my office day. I'm in the office all day. And that also starts very early. I try to get to the hospital between 6:30 and 7. And I go and make rounds on all the patients that I operated on Monday, make sure they're doing well. And then I come to the office to get started. Typical office day will start between 8:30 and 9 o'clock and end somewhere around 4 o'clock. And then either I have to go back to the hospital or I'm done and get to go home and do whatever with the kids. Wednesday is very similar to Monday. Wednesday, I operate all day. I typically start at an outpatient surgery center and then go back to Lourdes to do a bigger case that I've added on or had on the schedule. Thursday is another clinic day, but I'm typically done by 1 o'clock. And I keep the afternoon open in case I'm on call and have to add on surgeries or have meetings. I have a lot of meetings typically that happen on Thursdays for some reason, which is great. I was on the medical executive committee for 10 years, so we always had some sort of meeting to go to. And then Friday, if I'm on call for the weekend, my Friday is very busy. I try to do as many surgeries as I can, and then I work Saturday and Sunday through the weekend, etc. But if I'm not on call, I try to finish my day by about 3 o'clock on Friday so that I can go home and do whatever it is need to be done with all the kids.
Yeah, it's jam-packed week.
It's nonstop.
Yeah, it sounds like it.
Well, let's shift over into, I guess, the basics of colorectal cancer. So we know it's the third most common cancer diagnosed in men and women in the United States, the second highest death rate in men, third highest death rate in women. I was hoping you can kind of give us sort of like an overview of its signs and symptoms.
All right. So the first thing I'll say is that in a woman, lung cancer is first, breast cancer is second, colon cancer is third. In a man, lung cancer is first, prostate cancer is second, colon cancer is third. So third most common in both sexes. The only difference is number 2. Signs and symptoms of colon and rectal cancer is a problem, and I'll tell you why. It's the same thing for, I'll relate it to 2 different cancers, breast cancer and a woman. Most of the time, you have signs and symptoms from the cancer, it's too far gone. These cancers are slow growing. They take years to form, years to grow until you notice a single sign or a single symptom. Okay. So, specific to colon cancer, abdominal pain. Abdominal pain is common in colon cancer. Unfortunately, though, it's common in the latter stages when the cancer has grown and progressed. When it's in its early stages, you don't feel anything. Blood in your stool, rectal bleeding. Well, most 99 out of 100 times somebody sees blood in their stool or on toilet tissue or whatever, it's from hemorrhoids. It's not from colon cancer. Colon cancer rarely bleeds enough to notice it. It's a slow bleeding tumor to where you can't detect it by the eye. Change in your bowel habits. So some people, colon cancers can make them constipated. Sometimes it can make them have diarrhea. What that though is that typically the tumor is so large, it's either making you constipated, and to overcome that constipation, your body floods the colon with water to make you have diarrhea so it can get around the tumor. Again, you start having these symptoms, it's too far gone. Anemia. Anemia is obviously low blood count. That's typically picked up on a blood test. By the time you become anemic from a colon cancer, it's usually more advanced. Fatigue, obviously, fatigue and weight loss, we'll put those 2 together. Those are typical of more advanced cancers, regardless of what kind of cancer it is. By the time you get colon cancer that's spread all over the place, it'll make you tired. You'll have weight loss because the tumor is beginning to affect your entire system. So, unfortunately, for colon cancer, signs and symptoms typically happen in a more advanced state. There's almost no signs and symptoms for earlier stage colon cancer.
Wow. And so, I mean, the best way to really stay on top of it would then be to just screen when you're supposed to be screening and going to your appointments then, right? If it's to get ahead if you want to catch anything early.
100, and that's why we're here. 100%. The most important thing is to get your colonoscopies. Don't, not only do you need a colonoscopy, do not ignore a symptom. I'll give you an example. The, the problem with the internet is that it's the internet. If you Google your symptoms, it's either going to tell you have cancer, which you probably don't, or it's going to tell you nothing's wrong with you to ignore it when something could be wrong with you. And so I tell people all the time, get off the internet, stop Googling your symptoms. If you feel like something is not right, trust your gut and go see your doctor.
Yeah, definitely. I think that's great advice. And when you see something on the internet, you can always convince yourself either way. You're like, well, okay, I'm going to agree with the one that says I'm not sick because I don't want to believe I'm sick, you know? And so it's always best to get it checked out. And it sounds like too, a lot of these symptoms are they're hard to recognize because you could just think, oh, I ate a bad meal or I ate something that didn't sit well with me. And so who would you say is most at risk of developing colorectal cancer? Are there certain genetic influences or even lifestyle influences that could give someone more of a chance of developing this type of cancer?
Yeah, 100%. Risk factors is what we're talking about. So obviously advanced age, colon cancer is much more prevalent over the age of 65. But over the last 20 years or so, that age is starting to drop. The average age of detecting colon cancer has dropped significantly enough to where they're starting to drop the age requirement for colon cancer screening. So that's the number one risk factor is age. Okay, which age is the number one risk factor for most cancers. Another one is your own personal history of having a polyp on a previous colonoscopy. Once you get a polyp, you are at higher risk to continue to get polyps, and you're at higher risk for those polyps to grow and become cancerous. Next, family history. Most colon cancers are sporadic. Sporadic means it does not run in families. Okay. I have so many people who come to the office, first time colon cancer diagnoses people, and they always say, but no one in my family has it. Well, if you think about it, someone has to be first for it to run in family, correct? So unfortunately, those are the bad luck people that get it. They're the first family member. Well, guess what? Now it runs in you. So all your siblings and all of your children now are at increased risk to get colon cancer, despite no one in the family ever having colon. Okay. Diet. Diets that are low in fiber, high in fat. That's the South Louisiana diet right there. Yeah, I'm telling you, it's just, we do not eat healthy here. And it is what it is. There's not much I can say to that, other than a lot of people who come here that have, I get so many people who come here and say, oh my goodness, my brother had colon cancer. I want to do something to help myself. First off, they need a colonoscopy. The next thing is I tell them, eat a little bit healthier. Okay? You don't have to completely change your entire life to revolve around the situation, but maybe eat a little less fattening food, eat out a little less, eat less red meat, and eat a little more fiber. You don't have to completely change every single aspect of your life. You just help it a little bit by altering some bad habits. Everything in moderation is what I like to say.
I wanted to touch a little bit on the age range that we talked about, it dropping from around 50 as the suggested age range to 45. Is that something that you're seeing in your own practice? This sort of like younger age group that's getting colorectal cancer?
Yes, absolutely. It seems like every year trumps the previous year, meaning every year I get someone who's younger than they were the previous year who gets diagnosed with colon cancer. And so, thankfully, several years ago, the American Cancer Society came up with some sort of task force, and they were looking at the numbers, and they ultimately made the decision that it was time to recommend that people go from 50 to 45 in screening colonoscopies. Now, COVID halted a lot of that stuff, so now we're starting to see more and more of these people who are in between the age of 45 and 50 being referred to our office to get their colonoscopies. Finally, it's starting to to catch on. But yeah, no doubt, there's been a major shift in the last 20 years, age related regarding colon cancer. All
Yeah.
right. So after that is a sedentary lifestyle, and I'll clump obesity in that together. Obesity is a risk factor for all cancers. It is known that the larger you are, the more at risk you are for multiple different types of cancers. And so that goes along with the changes in diet. Add a little bit of exercise to your diet, and you can help prolong your life. Just on TV, they always say 30 minutes a day. It doesn't matter. 30 minutes, 3 days a week, just a little something more than what you're doing
Mhm.
now. It is really helpful. Again, the goal is not to tell everyone to completely change their lives. The goal is just to modify some of your behaviors to make yourself more successful and to live longer. Other things that you can easily do is for smoking and alcohol use. People, I'm telling you, people in South Louisiana love to drink, and I always tell them, man, you can't drink that much. You can't drink a six
Mhm.
pack of beer a day. Cut it down. Do a 6 pack a week. Again, a little moderation there. Smoking cessation. Boy, smoking is associated with every single type of cancer known to man, along with heart disease, stroke. It's a myriad of other problems. So people that can quit smoking is huge. Diabetics, diabetics are at a higher risk for getting colon cancer as well. And for the diabetics, it's weight loss, diet changes, control your sugar,
Mhm.
modifications like that can help you keep going. Those are all of the major risk factors that I've listed.
Okay.
Yeah.
Well, then, if we want to talk about screenings, then next with colonoscopies, I think we realize that it's sometimes a scary word for patients. They might be uncomfortable talking about it. They might be a little bit embarrassed about it. So, what do you tell your patients to kind of help calm their fears?
Okay, so let me tell you, let's put the age at 45. I can guarantee you that less than 50%, much less than 50% of people come at age 45 to get their colonoscopies. It is a very low number. Even when it was age 50 was the recommended age for screening, less than 50% of people came at the age of 50. So it's a low number that come. And the reason is because there's a stigma associated with it. Who wants to have this done? I certainly don't want to have this done, but yes, we're open to get it done. It's necessary, but it's a simple thing. So if someone comes to my office who is referred to me for a colonoscopy or who called the office just to get a colonoscopy, they come in, they sit down, and my job is to put them at ease. This is actually something that is very simple. The worst part of a colonoscopy is the day and night before the colonoscopy. And the reason is the day before you cannot eat. You're on a liquid diet all day. And believe me, there are some human beings that think they can't go a day without eating. So that's devastating to some of these people. And then toward the end of the day, they have to drink the prep. The prep is the substance that you take, and there's several different kinds, and it's going to make you go to the restroom half the night. It's miserable, but it's the best that we have right now. And if you can get through the day and that evening, then the day of the procedure is so easy. These are mostly done at outpatient service centers. You get an IV. That's probably the worst part of the procedures to get an IV put in you, and you get put to sleep. You're not all the way to sleep, but you're out enough to comfortably undergo a colonoscopy, and you don't remember anything. Once you're awake, most of the time, the physician or nurse practitioner will come and talk to you afterwards to tell you kind of what they found, what to expect, and when the next one should be. Most of these are done in the morning. Most people are home for lunch. Very simple. You can even go to work the day before because the prep doesn't start typically till after 4 o'clock. It's the next day that you'll have to miss work, which is the day of the procedure. And then the day after the procedure, you're free to go to work as you please.
Well, so when the colonoscopy is happening, are we looking for cancerous polyps, and then we're trying to, I guess, determine what the treatment is based off of that, right? Is it automatically an
100%.
indication of cancer?
No. So when we do colonoscopies, we're looking, obviously, we're looking for masses and polyps and things like that. When we do these colonoscopies, there most of the time we find small polyps between 3 and 5 millimeters in size. Those are easily removed during the time of the colonoscopy. Even much larger ones can be removed at the time of the colonoscopy. But unfortunately, There are some colonoscopies where a polyp is too large to be removed, but it doesn't mean that that polyp is cancer. It just means the polyp can't be safely removed with a colonoscopy. Those people unfortunately have to have surgery, but you would much rather have surgery for a large benign polyp than you would have surgery for a big cancerous polyp. So those people typically, if we can't take out a polyp, they wake up, we go talk to them, they come back to the office, we set them up for an elective surgical procedure to get rid of it. Those typically go very well. The problem is when get in there, we find large cancers. That's when this becomes very complicated. Now, I think we're going to get into that as the podcast goes. But yes, we're looking for small polyps that we can remove. If we can remove the polyps, their interval will decrease in the next time they need a colonoscopy, but at least they don't have colon cancer.
Yeah, that's true. And would you say for a colonoscopy success rate, are they very successful at detecting cancers early? And why is it important to detect them early if that is the case?
Yeah, so the whole point of this is actually to detect it before it becomes cancer. The whole point is to find it in the polyp stage so we can take it out. No one wants to be told they have cancer. None of us want to tell people they have cancer. Boy, my life would be a lot easier if I didn't have to do all these surgeries on people for colon cancer. But it is what it is. We do find bad things, unfortunately, and the goal of it though is to catch it in its early stage. And the goal of it is to catch it in its early stage for multiple reasons. Most of the time, early stage cancers will need to have surgery and then they're finished. They do not need radiation, do
Mm.
not need chemotherapy. They just need colonoscopies a little bit more frequently. They don't have to have any of that other stuff done to them post surgery if we can catch it in an early enough stage.
Well, we wanted to touch a little bit more on alternative screening methods for colorectal cancer other than a colonoscopy. We've heard about at-home tests like Cologuard. So I was curious about your thoughts on those, if you can explain some of those options and how worthy they are.
All right, so yes, I'd love to. Let's just talk about Cologuard because really there's not many other good tests to do other than Cologuard. So I'm going to badmouth Cologuard because we're not a big fan of it in my community, nor in the gastroenterology community. And the reason is because if you listen carefully to the Cologuard commercial, it detects colon cancer in its earlier stages, but it does not detect small polyps. The whole point of this is to get it in the polyp phase, not get it in the cancer phase. So Cologuard has a high false positive rate. High false positive means that you send the test off, it comes back as a positive. You have to get a colonoscopy, and the colonoscopy is clear. They don't find anything. Okay. Well, that's fine. I would much prefer a false positive. The problem with Cologuard is the false negatives. You have a negative test and they say, oh, hey, you're good. You don't need another test for 5 years. Well, you have something terrible growing inside of your body. And so I never ask people to do those tests. Now, there are many people who are so adamantly against getting colonoscopy that I think Cologuard is great for them. Hey, there might be something bad in there, but if so, maybe Cologuard could detect it and we can get it. It won't be in its early stages, but maybe it won't be stage 4. Okay. So that's the biggest problem with Cologuard. Now, over the past few years, they've tried some other tests, and I'll be very brief with this because they've all gone by the wayside. There was a fit test that was done for a few years, like from around 2005, 2010. That turned out to be maybe useless. And the other one was called CT colonography. And they would do CAT scans on people with dye in their bowel and try to find polyps and stuff like that. Well, the problem with that is that you have to clean out to get the CAT scan. Then you would get your CAT scan. And if the CAT scan showed anything, you'd have to go get a colonoscopy. So what's the point of getting cleaned out for the CAT scan when you can just get cleaned out and go get your colonoscopy? So that also was trying to become popular sometime between 2005 and 2010. It gained a little bit of popularity, but once people started realizing, wait a minute, now, why am I getting 2 tests? They just kind of scrapped it. So no one's really doing that anymore either. That really the people who get that are the people who are so adamantly against getting colonoscopies.
Yeah, that's great to know it's not basically to replace a colonoscopy. it's definitely more important to go and get your colonoscopy over just settling with a Cologuard test.
Listen, 100%. The best thing we have right now is colonoscopy. Yes,
Yeah,
in the future, there may be something better, but the best thing we have right now is colonoscopy.
definitely. Yeah. Well, I know we're getting close to the end of our time together, and so I was just curious, what are you most excited about for the future of colorectal conditions and the care of what's to come?
The goal is to eradicate this, right? That's the goal. If more people would go get the colonoscopy, they could potentially put me out of business, and that's fine. That's what we want. I do not. Okay, I love taking colon cancer out of people because we can cure them, but I also don't like taking out because I don't like having those conversations with people.
Yeah.
It's not a good day when I have to tell somebody they have cancer or how bad their cancer is, talk about chemo and all that kind of stuff. But for the future is in genetics. The future is to try to figure out the origin of this because we still have no idea. Yes, they mapped the DNA genome, RNA genome, all that kind of stuff, but we still have no idea why people begin to form polyps. Yes, there are some people who have a genetic predisposition to get colon cancer, but I'm telling you, those numbers are much on the wayside as opposed to sporadic colon cancer, which is colon cancer that just happens to be.
Mhm.
Most colon cancers are sporadic, most are not familial or DNA related. So, why are these people sporadically getting colon cancer? And genetics is going to be the way that we figure it out. We're not even close to that point yet. It's going to be the same thing for most of the other cancers as well.
Yeah, very interesting.
Yeah.
Well, we wanted to kind of give you an opportunity to show us a little bit of a personal side before we wrap up. We, pride ourselves on being the health system that listens. So the question is, what are you listening to these days?
So, we all, physicians are always there's always new things coming out, always. And that's why I still get a magazine every month, and we look through them. I try to keep myself up to date with doing continual medical education. And to be honest with you, more of what I'm reading and more of what I listen to does not have to do with colon cancer. It has to do with many other things that are interrelated. And a lot of it is patient care. So who is at higher risk to get all this stuff? Those are the people that I need to say, hey, look, not only are you at higher risk to get colon cancer, you're also at higher risk to get this other cancer, and you need to go see your other doctor and get this test done. Because when they come to see me, my job is not just to say, oh, hey, how are you? You have cancer, let's have surgery, adios. It's let's talk about you. When people who have cancer come to the office, they get more time than everyone else does. That's the most important person of the day is the person
Mhm.
with cancer. The visits are longer, the emotions are higher. They usually have more family members with them to ask questions. All together, it's a much bigger deal than somebody who's coming in here for a benign problem. My
Mhm.
job is to listen to them, but my job ultimately is to be as educated as I can so that I can give them the answers that they need. Unfortunately, so often the answers I don't know. And those are the questions like, why did this happen to me? Why am I the only family member that has this? Why is it so far gone? And the answer, unfortunately, for that is I don't know. And that's something that none of us like to say to people. And that's why we,
Mhm.
we listen to the patient, we listen to the family member, we listen to all these other societies that are giving us our information that we need to carry on about our business on a daily basis.
Definitely. That's really refreshing to hear. Thank you so much, Dr. Boudreau, for joining us and for, sharing your expertise with us on correctal conditions. Is there anything as we close out that you want our listeners to know, the one thing you want them to remember and take home with them?
Absolutely. A large study was done in Louisiana about 10 years ago, and it had to do with colon cancer or all cancers, honestly. And they found that the Acadiana parishes had the highest incidence of colon cancer in the entire state. So
Wow.
if you're a Cajun person of Cajun heritage in an Acadian parish, you've got to go get your colonoscopy.
Wow. You heard the man.
Yeah.
Head to Our Lady of Lourdes and get your colonoscopy.
There you go.
In your daily life, what inspires you to continue doing the work that you do? How are you inspired?
So Great question. I'm from Scott, Louisiana. My dad is from Scott, Louisiana. My grandfather, my great grandfather, and my great grandfather. We're all like our family is from Scott, Louisiana for 200 years. We're Cajun through and through. And when I did all my training in Shreveport. I was up there for 10 years. And every day that I was there, I could not wait to come home. And so
Mm.
what inspires me is helping the good people of Acadiana. That's what inspires.
That's wonderful.
It's a good answer.
That was shooting from the hip.
Oh, it was perfect.
Thank y'all.
Thank you. Thank you so much for joining us, Dr. Boudreau.
Thank you for having me.
We're so grateful for your expertise and for just sharing all of your knowledge and the compassion you have with practicing care. And for our listeners, thank you so much for tuning in. We'll have everything that Dr. Boudreau mentioned and other helpful resources linked in the show notes. We'll be back soon with more episodes of The Doctor Will Hear You Now, a podcast from Franciscan Missionaries of Our Lady Health System.
And if you have ideas for topics you'd like to hear on the show, email us at podcast@fmolhs.org. Thanks for listening.